You've already had Matt referenced a couple times this morning. He is a researcher at UBC in the Pacific Parkinson's Research Center. He's under the supervision of Dr. John Stossel. And the focus of his research is looking at the therapeutic mechanism of exercise in Parkinson's disease. And he's spoken quite a few times for us now. It's really quite exciting to see some of the information that's coming about via the research. And he's also recruiting people to participate in the research. So if you're interested, and he doesn't get to answer your question because we will have a Q&A at the end of his presentation as well. All right, so over to you, Matt, and welcome.
So thank you very much for the introduction, Jean. I've spoken at these events kind of throughout BC a couple times, and every time I add a little bit to each presentation, so I'll try to go quickly so we can get to the exciting stuff at the end. So I'm a PhD student with Dr. Stossel at the Pacific Parkinson's Research Center, and as Jean said, I'm looking at the mechanisms of exercise for Parkinson's disease. So today what I'm going to talk about is how we actually study the brain in different areas, how that's influenced how we've designed our exercise studies, and then show you a little bit of the preliminary evidence that we found in some of our first couple of studies, and then what we're doing with that information moving forward. So this beautiful building right here is the David McGavian Center for Brain Health at UBC. It was built a couple of years ago, and it's a joint venture between UBC and Vancouver Coastal Health. And the unique part about this building is that it has both clinical care in there, so this is where the Pacific Parkinson's Research Center is, but it also has all of the basic neuroscience conducted in this center as well. So the first 2 floors are clinic space, and then the top 3 floors are all research space. And the idea behind that is to be able to integrate what we learn from basic neuroscience and be able to integrate that directly into clinical care to try to bring those, bridge that gap between the basic neuroscience and clinical information. So some of the research currently going on there is this really wide range of different types of neuroscience. For example, one end of the spectrum, we can have molecular neuroscience. So for example, this is studying specific molecules and chemicals in the brain and how, for example, genetics might influence these things. And this is something that Mattia Volta was working on at the Center for Applied Neurogenetics. And this is, again, housed in that Center for Brain Health. And he was looking at how dopamine interacts with a specific gene called LRRK2. If we take it one step further, we can then look at cellular neuroscience, or the specific study of cells in the brain. And that's what these nice, bright, colorful images are. These are actually brain cells here that are labeled for different things. So all of these different colors are actually different connections that cells make with each other in the brain. And they're quite beautiful images. So this is something that Nyla and Chelsea are working on, again, at the Center for Applied Neurogenetics. We can then take that cellular information and put it into an animal model. And this is called behavioral neuroscience. So something that Paul Cocker is working on is he's looking at the behaviors of different mice and how they can actually gamble. So he looks at the effects of dopamine on different gambling aspects in these mice. He doesn't necessarily get them playing slot machines, but this is in essence what he's studying. And this has huge impacts for Parkinson's disease in terms of things like impulse control disorders. So we can take all of that together and then study it in people, study it in patient populations, and this is clinical neuroscience. So myself and Dr. Dara Weil, who is a fellow at our center and is now a neurologist in Kelowna, we did different neuroimaging as well as a number of other researchers at our center. So all of us, the reason why I've highlighted all these different people is we're all funded by the Parkinson's Society of Canada, and we all study at UBC at the Center for Brain Health. So it really shows the strength of the Parkinson's program at UBC in Vancouver, and this will also spread throughout the whole province. So I think this really shows a good strength of BC in general for Parkinson's research on a national level. And all of us are really focused on brain function from different aspects. So we want to look at how the brain works, what happens when the brain is damaged, and how can we repair that. And that's really one of the areas that this Center for Brain Health is really focusing on, is how does this brain work? So what I've done is I've taken these questions and related them to exercise, because that's the focus of my research. I come from a kinesiology background, so I'm really interested in the aspect of exercise. So you want to say, well, how does the brain work with exercise? How does Parkinson's disease change the brain? And can exercise help repair those damages we see with the disease? So let's look at that first question. Well, what happens with exercise and the brain? Well, we see exercise can improve cognition, it can enhance learning, facilitate memory, and decrease age-related cell loss. So as you age, cells will begin to die over time. And exercise might help to stave off some of those cell loss. And we see evidence of this in molecular, cellular, behavioral, and clinical models of this disease. So we're able to study this across the wide range of neuroscience and see evidence that exercise is beneficial for the brain. So that's great. The next question, well, what happens with Parkinson's disease in the brain? Well, Dr. McEwen already alluded to this a little bit, and it's the loss of dopamine cells in the substantia nigra. And this decreases the amount of dopamine that's projected throughout the basal ganglia. This will cause motor and non-motor symptoms, and there could be environmental and genetic factors and a combination of both that might cause this specific loss. So then, how does exercise fit into this? Well, if we look at exercise in the literature for Parkinson's disease, we see this wide range of different types of exercise that claim to be beneficial. One aspect, you might get really high intensity exercise like cycling or running. As Doug pointed out, boxing is a new big thing coming up. There's a big 60-minute special done in the States where they showed this group called Rock Steady Boxing. There's also group aerobics or resistance training. Tango and Tai Chi. There's a group out of New York looking at dance in the Parkinson's disease. And then there's also more slow-moving and balance-based, like Tai Chi and yoga. So there's a really big randomized control trial published in the New England Journal of Medicine, which is the top journal to publish clinical trials in. And it showed that Tai Chi actually improves balance and motor symptoms even more so than resistance training. So we see this wide range of different exercise interventions, and we see improvements in motor complications. So the typical symptoms, motor symptoms of Parkinson's, like tremor, rigidity, balance. But we also see improvements to gait, muscle weakness, and aerobic fitness as well with different aspects of exercise. We also see non-motor complications, so things like cognition, mood, depression, sleep, or autonomic dysfunction. For the patients, we also see improvements to activities of daily living. And I think this is the most important aspect of exercise in Parkinson's disease, because this means it's actually helping the patients. It's helping you guys get out of chairs, help you get dressed, maintain your independence overall, prevent falls. I think this is really the strength of exercise within using it as a therapy. But as a researcher, I'm really excited about the neuroprotection aspect of exercise. There's evidence of animal models that exercise might actually prevent further death of neurons and restore or help regrow neurons that have died. And this is quite exciting from a science aspect, because if we can show this in clinical populations, that will be quite influential. So the question I always get when I present at things like this, when I show this slide, is if exercise is so great, what should I be doing? Write me my exercise prescription. What's the ideal thing I should do? What frequency, how much should I be exercising? What intensity should I be exercising at? What type of exercise is the best? And how long should I be exercising for? And to be honest, we don't know this answer. No one knows this answer. And if someone tells you this is the best thing that you can do, I wouldn't necessarily believe them, because there's so much information out there and so much research that's been done in this area, and yet we still don't know this answer. So we're taking an alternative approach to this question, and instead of looking at the specific types and frequency and times, we're going to take a step back and actually try to identify a mechanism. If we can understand how exercise is changing the brain, this will then lead us to the best types of exercise or intensities to induce those changes in the brain. So now I'm going to get into a little bit of the research that we've conducted so far based on this mechanism question. So the first study we conducted was a study with Dr. McEwen and Dr. Cresswell, and we wanted to study the brain and body connection. So trying to understand how the electrical activity of the brain influences the electrical activity of the muscles, and if there's a connection there, and if there's differences between people with Parkinson's and people without Parkinson's. So we also had clinical assessments of motor function and mood, and then again assessed how the brain and muscles were behaving. So this is one of our beautiful subjects here. She was very kind enough to let me use her picture. So what we do is we wire the head with an EEG cap to again measure the electrical activity of the brain, and then wire the lower legs, and we get someone to cycle at different exercise intensities. And we can monitor how the brain is functioning and how the muscles are functioning while someone cycles. And how we study the brain, instead of just looking at one little electrode in one area of the brain, Dr. McEwen alluded to there's a whole network, and these different brain areas are going to work together. So we wanted to look at connectivity, or how a whole network of these neurons are actually working. Likewise with the muscles, we don't want to just look at how one muscle is working, but how they're working in concert with each other together to actually allow someone to cycle. So what did we find? Well, we did a UPDRS, or a Unified Parkinson's Disease Rating Scale, which is a motor symptom severity scale. And we showed after exercise, there was a marked reduction. And this is after 15 minutes of cycling. That's it, not a lot. And we see this improvement of about 5 points, which is clinically meaningful. And this improvement seems to last after about 2 hours after exercise. So it shows that there is some benefits that last throughout a day, which is good. For finger tapping, so this is a test where we get someone to take their finger and bounce back and forth. And it's a measure of bradykinesia, or the slowness of movement. And we see both controls, which are the red line here, and the PD groups improve after exercise. So exercise seems to improve movements overall. This next test is a test of apathy, or your mood, or how you're feeling. And we see both the controls and PDs improve after exercise. And this seems to last over time. Even more so, it seems, in the PD group. So people feel better after exercising, and this is some evidence of that. But what does that actually mean in the brain? Or what does this actually mean in the muscles? Is this a result of actually doing the exercise? Well, when we looked at the muscular network, we've seen that the muscles in people with Parkinson's disease and people without Parkinson's disease behave quite similarly. So there's a similar muscle output being generated, and people were cycling very similarly, which is good. But in went too fast. In Parkinson's disease, the brain network was actually a little bit different, and we're able to differentiate between people with Parkinson's and people without with this new brain network. So it shows that the brain is acting differently, but the muscles are acting the same. So what does this mean overall? If we correlate this to UPDRS, we actually see quite a nice correlation. So as disease severity goes up, this brain network is expressed more and more. So it could possibly be compensation. So when we look at this brain network and we compare it to other brain networks identified in the literature, there was some evidence that it might be related to rigidity. So we looked at rigidity specifically as a symptom to see if this brain network was related to it. And there was no correlation. So it's unlikely that this is due to an increase in rigidity. This brain network has also been associated with postural instability. So we thought, well, maybe people with Parkinson's disease need to activate this network to stay upright on a bike as they're cycling. So that's a possibility. But the thing that we're most excited about is that this sensory motor integration. So there's a theory with Parkinson's disease that the basal ganglia, the part of the brain that's affected by Parkinson's disease, actually integrates different sensory information. So if I stick my arm out to the side and I close my eyes, I know that my arm is out at the side. And that's called proprioception, or limb awareness in space. And in Parkinson's disease, there's a deficit of that. So there's a lack of information that's being processed in the brain. And it could be that this increase in this brain network is trying to help compensate for that sensory motor integration deficit that we see. So in summary, we see a single bout of exercise improves motor symptoms and mood in Parkinson's disease, which is beneficial. We see that Parkinson's disease and control subjects have similar muscle activity but different brain activity. And this brain activity might be a possible compensatory network, which all seems great. However, with all research, there's limitations that we need to consider and future directions that guide our research. So the first limitation is all these subjects were habitual exercisers, meaning everyone we recruited for this study are exercised for a good portion of their life and are very active at the point. So perhaps this brain network is just specific to people who exercise. So we need to look at people who are non-exercisers. Also the type of exercise. We just studied cycling in this exercise paradigm, so we need to look at other types of exercise and also different intensities of exercise. What happens if we go really, really slow or really, really fast? Are we going to see different brain networks activated? We also want to look at, this is just 15 minutes of exercise, right? It was just a single bout of exercise. So what happens with multiple bouts of exercise? Are we able to make this brain network perhaps more in tuned in our brain or make it more integrated? What happens when you're a whole lifetime of exercise? Is there actual brain differences between these two groups? And that last question, this whole lifetime of exercise, led us to our next study. So this study, we took people with Parkinson's disease who have been very, very active, and we studied their brains. And we compared them to people who were just hanging out and not as active. And we compared them in our PET scanner, so positron emission tomography, which allows us to study specific cellular behavior, in this case, dopamine release in response to exercise. We also looked at brain activity in response to reward with fMRI, and then motor function, mood, depression, and apathy, and cognition. So what did we find? Well, we found when we compared these two groups at baseline, the group in blue here is our exercisers, and the group in the red here are our non-exercisers. So we have one group that's very active, one group that's not active, and we see a tug test or a timed up and go test, where I get a patient to sit in a chair, stand up, walk 3 meters, turn around and come back and sit down, which is a very simple task, but it's very functional. You do it in everyday life, and we show that the group that exercises a lot is able to do this faster. They have better functional gains, so they're going to perform these activities of daily living at a faster rate. So this shows that exercise actually influences these sort of things. Again, this is finger tapping, so going back and forth with your finger, a measure of bradykinesia. And we show that the blue bars, the people who exercise, are able to get more taps, so they're able to move faster. So it shows motor improvement with exercise. For mood, this is apathy score, so we show that exercise or a lifetime of exercise, people have less apathy. They feel better during their everyday life compared to people who don't. But is this actually stemming from neurological differences within their brains? So these fancy images here are our PET images, and these are two examples that I'll show you. So the first one up here, this is our habitual exercising group, so the group that have been exercising their entire lives. And what we do at baseline is we do a baseline scan to find out the number of receptors for dopamine in your brain. And then we put you on a bike for 30 minutes and get you to cycle for 30 minutes, and then we pop you right back in the scanner for post-exercise. And we're able to measure the amount of dopamine release with that exercise bout. So I'll highlight these kind of red, warm colored areas, the red and yellow. That means there's radioactivity in that area from our tracer. So it means there's not a lot of dopamine released in that area. But I'll show you after exercise, specifically in this little area, that red-yellow area went away. So that means there's no more radioactivity, and it means there's dopamine release in that area. If we compare that to someone who isn't exercising, we see that, again, you have that warm colors here at baseline, and after exercise, there's no real difference in those warm colors. So there was not a lot of dopamine release. So graphically, it looks like this. We see this is two areas of the brain on the better and worse hemispheres, and we show that the blue bars, the people who have been exercising, release dopamine more than people who don't exercise. So in summary, it shows habitual exercisers increase dopamine release, improve motor symptoms, and have less apathy. So it seems that habitual exercise is beneficial for Parkinson's disease. But as I said earlier, with all research, there's limitations. So this is what was called a retrospective cohort study. So we are just doing a study comparing two groups at one point in time. So there could be a number of different reasons why we see these differences, and it might not just be related to exercise. It could be things like different pathology, different environmental factors, different genetic factors that also might influence these changes. We also used exercise as a stimulus for dopamine release. And this might be different as both these groups were in different fitness levels, so their intensity of exercise might be slightly different. And also the enjoyment of exercise. If you get someone who's been sitting on the couch for a majority of their life and you ask them to cycle for 30 minutes, they're probably not going to be too happy with you. But if you get someone who's been training for marathons, they're going to love to exercise and really enjoy that exercise. And we know that dopamine might be influenced by this enjoyment factor, so that also could be contributing to these differences we see in dopamine release. So the question that I was kind of left with at the end was, can someone who is non-exercising, can they actually become an exerciser? And so that's what led me to the study that we're currently conducting. is trying to understand the therapeutic mechanism for motor and cognitive benefit. So what we're doing is we're taking people who are not exercising and we're enrolling them in a 3-month exercise intervention. So we want to see, does 3 months of exercise increase dopamine release? And instead of doing dopamine release with exercise, we're actually going to stimulate your brain superficially. And then we're also going to look at neuroinflammation. Dr. McEwen noted that inflammation in Parkinson's disease, there could be a relationship there. We actually think exercise might decrease the amount of neuroinflammation, which is why it's so beneficial. So we want to be able to study that. And we're also looking at neuroplasticity. That's one of the big things that drives Becky Farley's POWER program, but it's very difficult to study. So we're going to try to show it with some of our other neuroimaging techniques, such as fMRI. We also want to see disease progression. So there's a lot of anecdotal evidence out there that shows that exercise might actually be beneficial for disease progression long term. But no one's actually been able to prove this. So we're going to enroll people for 3 months and then buy them a gym membership for 3 years. And we want to have them continue to exercise for that 3-year period of time and then track disease progression with neuroimaging. So then we're not just doing a clinical study or a questionnaire to track disease progression. We're actually going to study the number of cells in your brain. And we're also, again, going to look at neuroinflammation to see if there's a relationship between that and disease progression. So this is one of our latest slides. This is a little bit of tantalizing evidence from this first trial. So this is the first 4 people enrolled in the study that have completed pre- and post-exercise. So the green bars here, these are different regions of the brain, and this is dopamine release. The green bars are before exercise, and we don't see a whole lot of dopamine release over this period of time. However, after exercise, which are the purple bars, we see increases, which shows great. So why am I not publishing this yet? Well, these black skinny bars actually show the variability of this data. So this data is highly variable, as exercise influences every person differently. So this is the first 4 people. It shows that we're on the right track, but there's still a lot of work that needs to be done to solidify this result. So I just give you a little bit of a tease. Hopefully in a year or 6 months or so, we'll have a better answer and a better idea. But for now, this is what we have. So the take-home messages from this presentation I want you to leave with is, can exercise actually change the brain? In PD, it shows that there might be some facilitatory compensatory mechanisms that are induced by exercise, which is really beneficial. It shows long-term exercise or a lifetime of exercise seems to be beneficial. It shows that these changes might be related to dopamine release, and that could be why they're so beneficial. But what should you actually be doing in terms of exercise? My recommendation for you is do what you enjoy. The only way you're going to get the beneficial effect of exercise is if you actually exercise. And the only way you're going to exercise is doing something you actually like. If you don't like to swim, then don't go swimming. If you don't like to run on the treadmill, then don't run on a treadmill. But find something you really like to do and do that. Do what you can tolerate. Don't push yourself so much that it's affecting other things you want to do in your life. I've heard of people saying, I get up and I ride my bike for 2.5 hours in the morning and I feel great, but that evening I can't go play bridge with my friends because I'm so exhausted. I would say exercise is not being beneficial for you then. It's actually being detrimental. So you have to monitor your fatigue, monitor your body, and you know your body your best. So kind of gauge that, use that as your guide. And also switch it up from time to time. Don't always do the same exercise every single time because your body will get used to that and then you won't see the benefits long term. So keep your body and your mind guessing. Change up the intensities a bit. Change up the cadence if you're walking on a treadmill, or try walking outside, or switch it up from time to time. But really, more research is truly needed to harness the real potential of exercise in Parkinson's disease. So with that, I want to thank everyone who's helped out with this study, all the wonderful research coordinators who helped with recruitment, Danielle, who had helped a lot of the first 2 studies. And if you're interested in participating with exercise or any of the studies at all at our center, please send us an email or give me a call or send me an email, and we can certainly keep in touch. And I'm happy to answer any questions you guys have.
Thank you, Matt. So So again, some very exciting areas of research, and right here in, well, not right here, but in Vancouver. There have been some outreach programs, and Matt, did you mention where, if you wanted to participate in any of this research, do you actually have to come to UBC?
Yeah, for the most part, all of our neuroimaging is conducted at UBC. It might be a little bit difficult in Nanaimo here for an exercise program per se, but there's ways that we bring people over from the island, so we pay for ferry fees and we can put you out for a couple days on campus if we want to do some neuroimaging, so there's certainly ways around it if you are interested.
So no excuse. They've covered it off. And we at the Society are really trying to ramp up making more programs available through doing Train the Trainer. So you'll know about Becky Farley's program. We are bringing the Dance for PD Train the Trainer to Vancouver in September. And we can't get rock steady up here, but we're looking at some kind of a subsidy program to get people down to Indianapolis to get trained. We will have 4 trained Rocksteady people in Vancouver by the end of June. So we are looking at different ways that we can provide resources out in your communities, and we're happy to have ideas flow from you to us.
I just have a question regarding the intensity of your exercise. They say you should get your heart rate up. I have no idea how long you should keep it up, or what do you suggest, or is it so individual that you can't really answer that? Yeah,
that's a great question, and it is, you're right, it is very individual. The Canadian guidelines for exercise is to keep it up for, I believe it's at least 20 minutes a day or something like that over a number of days, 5 days or so. So I would definitely try to keep it up for more than 20 minutes if you can, but obviously it helps to know your own body. If you can only do it for 15, then that's better than doing nothing at all. Yeah.
We have a step-by-step program that we launched last year as part of the Parkinson's movement for April Parkinson Awareness Month, and that might be something, if you have been sedentary, that you look into. We look for a volunteer coordinator in your community. They map out different routes for people who are just starting versus those who are already walkers. And one of the things about walking in a group is it does help you with a bit of the socialization aspect of it, so it builds some commitment. And the socialization aspect also does release some dopamine, so you can get a dual whammy from the exercise and the socialization. So if you haven't been exercising, that might be a way to get started. It's a 12-week program. You set a target to increase your distance and perhaps your rate every week, and so that hopefully also builds your muscle strength and your ability to walk. And Doug?
Was part of your research about the effect of exercise on Parkinson's, did you do anything about the effect of exercise on dyskinesias as a result of medication?
Yeah, we haven't looked at that specifically. The effects of exercise on medication metabolism, for example, is an area of research. It's a very difficult thing to actually look at and to study in clinical populations, as that changes in everybody. It changes by what you eat and what you've done in previous days and so on and so forth. So it is a difficult area. We haven't looked at it specifically, but anecdotally, I've noticed some of our subjects enrolled in the study have to take a little bit more medication to help with the exercise, as there's usually a greater motor demand during the exercise program, but it's really an individual difference.
Hi, Matt. Quick question. I often get asked by the people who come to my exercise classes, has there been any research or any, perhaps in your own experience, relation between the timing of your medications and exercise? What's most beneficial to help you get the most out of your exercise program?
Yeah, great question. I think you need to be, to get the maximum benefit of exercise, you want to be able to move the best that you can. So I think it really depends on the timing of your medications in terms of when you're best suited to do the maximum amount of movement. I don't know if Dr. McEwen wants to comment on any of the kind of timings of medications or whatnot. But that's what I would recommend, is trying to get the maximum effect of your movement, so timing your medication.
Some people notice that if they are more physically active, they tend to sort of burn through the Sinemet or levodopa a bit faster. So often what we recommend to people is before they're going out to exercise to take a little bit extra, typically maybe a half or a full of the yellow Sinemet, which is the 100/25 immediate release. Some people find that helpful.
I was just wondering if it has any effect with the major muscle groups like the arms and the legs. Does that help to release more of the dopamine, or is it just the small muscle groups and the smaller ones, would it help more?
Yeah, the dopamine release isn't necessarily associated with the muscle groups per se, it's movement in general. So the way we're studying it in the second part of the study is we're stimulating an area of the brain called the motor cortex, and we stimulate it at a very frequent rate, and it somewhat mimics your brain activity facilitating movement. And we do it at a subthreshold level, so we don't actually get movement in the muscles, but you get that same brain signal being sent, and that actually releases dopamine that we can measure. So I don't think it's necessarily, doesn't matter what muscle groups you're moving or whatnot, but just get moving in general is beneficial.
And Matt, once again, we so appreciate your work that you're doing, and then that you're willing to come out and share that information with us. So thank you once again.